4video, Ramsay Hunt syndrome, management and prognosis, the 72-hour window, vestibular physician. Welcome back, vestibular physicians, neuro-otologists, and clinicians. We've made it to the fourth and final explainer in our deep dive series on Ramsay Hunt syndrome. Over the past three explainers, we've covered the mechanics, that elusive clinical triad, and the diagnostic pathways. But today we are focusing squarely on the pragmatic clinical action plan. We're talking about the absolutely critical 72-hour management window. So, let's just dive right in.
I want to hook your attention immediately with this number right here, 75%. If you initiate early combination antiviral and corticosteroid therapy within 72 hours of symptom onset, your patient has roughly a 75% chance of complete facial recovery. Think about that. Treat within 3 days, and about 3/4 recover fully. Wait a week, that plummets to roughly a third. The clock is quite literally ticking the moment that patient walks through your clinic doors.
So here is our clear, evidence-based roadmap for today. We'll start with the 72-hour window, move into acute pharmacotherapy, then supportive care and rehab, prognosis and sequelae, and finally, prevention and vaccination.
All right, Section 1, the 72-hour window, the race against time.
As I mentioned, diagnosis and treatment are an absolute race against the clock. Just take a look at the stark contrast on this chart showing complete facial recovery by treatment timing. The spontaneous, untreated recovery rate way over on the far left, it's only about 20%. If you delay treatment until after 7 days, it barely bumps up to 30%. But when you administer that treatment within the first 72 hours, boom, we hit that 75% complete recovery mark. It's a game changer. The timing of your treatment is literally the single most dominant, modifiable factor in your patient's outcome.
Moving right along to Section 2, acute pharmacotherapy. This is the how of our management.
Let's look at this foundational 72-hour management algorithm. The absolute operational priority here is prompt combination therapy. Now, I'll be completely upfront. Randomized evidence for RHS specifically is a bit sparse, so we do extrapolate from Bell's palsy and general zoster data. But the observational signal is just too clinically compelling to ignore. If onset is within 72 hours, you need to start a combination of an antiviral and a corticosteroid ASAP. Please, do not agonize over choosing between equivalent oral agents. The crucial point is simply to get the therapy started.
Drilling down into the specific regimens, remember the governing principle, early combination therapy. For your first-line oral antiviral, we're looking at Valaciclovir, 1 gram 3 times daily for 7 to 10 days. Famciclovir at 500 milligrams 3 times daily is another highly effective alternative. We generally avoid oral aciclovir just because of its lower bioavailability. However, intravenous aciclovir at 10 milligrams per kilogram every 8 hours, that is reserved for your severe, disseminated, or immunocompromised cases, or for patients who just simply can't tolerate oral meds. Now for the steroid component, we use prednisolone at about 1 milligram per kilogram per day. You cap that around 60 to 80 milligrams, and then taper it off over 1 to 2 weeks.
Okay, Section 3, supportive care and rehab. Let's talk about the patient's quality of life.
I really can't stress this enough. Supportive care and Ramsay Hunt syndrome is never merely ancillary. It's totally fundamental. Step 1, you have to protect the eye. The eye is the organ most likely to suffer lasting harm from lagophthalmos and reduced lacrimation. You need a strict regimen. Preservative-free tears during the day, lubricating ointment and taping, or a moisture chamber at night. That is mandatory. Step 2, treat the severe otalgia and the resulting neuropathic pain, which, by the way, frequently outlasts the acute illness. Using gabapentinoids early on alongside simple analgesia is a very smart move. And Step 3, rehabilitation. Look, vestibular suppressants only belong in those first few acute days. If you prolong them, you're actually retarding central compensation. You've got to transition your patient quickly to structured vestibular rehab with active gaze stabilization, right alongside their facial neuromuscular retraining.
Now, before we move into prognosis, I want to leave you with this clinical pearl regarding surgery. Decompression is a last resort for neurophysiologically complete, non-recovering palsy and must never delay the time-critical medical therapy. Facial nerve decompression is still highly controversial. It's generally restricted to patients with total paralysis who show greater than 90% degeneration on electroneuronography within the first 2 weeks. And honestly, it should only be discussed within a neuro-otology multidisciplinary setting.
Let's shift to Section 4, prognosis and sequelae.
The long-term audiovestibular path. So this is the reality check phase of our explainer. Look at the sober reality of RHS when we anchor it against its most common differential, Bell's palsy. If we look at 2-year House-Brackman grade I outcomes, roughly 86% of Bell's palsy patients hit complete recovery. In Ramsay Hunt syndrome, that number is only 58%. RHS carries a significantly worse facial prognosis, and that right there is exactly why aggressive early medical intervention is completely non-negotiable.
And beyond the facial nerve, the audiovestibular limbs of this disease recover on very different timescales. The sensory neural hearing loss, it's deeply refractory. Complete resolution happens in only about 11% of patients. That's roughly 1 in 10. Vertigo, on the flip side, typically settles over a period of weeks as central compensation does its job. Also, keep in mind that special populations will modify your approach. Children, while rarely affected, actually enjoy much better facial recovery than adults do. And in pregnancy, corticosteroids remain your first line, and Valaciclovir has a reassuring safety profile, which makes combination therapy perfectly reasonable when you're co-managing with obstetrician input.
Finally, Section 5, Prevention and Vaccination, the future of care.
There is a defining tension in this field right now, summed up perfectly by this statement. Prevention now matters as much as treatment. We have relatively weak, extrapolated, observational evidence for our treatments, but we have incredibly robust, high-quality randomized trial data for prevention. That asymmetry should heavily influence how you practice today and how you counsel your patients moving forward.
The massive success story we have here is the adjuvanted recombinant zoster vaccine. It demonstrated efficacy exceeding 90% against herpes zoster in adults over 50 and over 70 in the big Zoe 50 and Zoe 70 trials. Widespread uptake of this vaccine reduces the incidence of zoster and, by extension, Ramsay Hunt syndrome itself. So your role? You need to proactively counsel your recovered patients, particularly eligible older adults and the immunocompromised, to get vaccinated once that acute illness has resolved to prevent future complications.
If you remember absolutely nothing else from this explainer, please commit this clinical action plan to memory. Treat empirically within 72 hours, rehabilitate the audiovestibular deficit, and counsel eligible patients on the zoster vaccine. That is the ultimate gold standard of care distilled into a single, powerful sentence.
This completes our 4-part series on Ramsay Hunt syndrome. We have moved from recognizing the rashless triad through mechanism and diagnosis to time-critical treatment and prevention. RHS is a treatable, time-critical audiovestibular disease that is too often recognized late. Thank you for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.
Before we officially sign off, I want to leave you with one final provocative question about your own institutional workflows. Are your frontline clinical systems truly designed to recognize the rashless triad before that 72-hour window closes forever? Because as we've seen today, once that window shuts, the trajectory of your patient's life changes permanently. Thanks for joining us.